Hello, everyone. My name is Samson Fine, and on behalf of the Genitourinary Pathology Society, I'm happy to welcome you to our virtual education series event this month on neuroendocrine prostate cancer. We'll be hearing from doctors Anu Gopalan, Michael Hafner, and Misha Beltran. And it's my privilege to co-host this event with Dr. Tamara Lotan, and I will hand things over to Tamara to introduce our first speaker. If you have questions during the session, please put them in the Q&A, and these questions will be curated by the moderators and asked to the presenters at the conclusion of their talks. Thank you so much.
Wonderful. Thanks, Samson. This is going to be a wonderful session today. I'm very excited about it. So our first speaker is a wonderful friend and colleague, Dr. Anu Gopalan. She did her residency at Weill Cornell, followed by fellowships in oncologic surgical pathology and also GU pathology at Memorial Sloan Kettering. Subsequently joined the faculty at Memorial, where she's been part of the GU pathology team ever since. Her research focuses on the clinical pathologic and translational aspects of prostate cancer, as well as adrenal neoplasms. And we're excited to hear her perspectives on neuroendocrine prostate cancer today. Welcome, Anu. Thank you.
Share my screen. Minute. Sorry about that. Do you see my screen now?
Yeah, looks great.
Okay, great. So thank you, Tamara. Good afternoon, everyone. Thank you to the GUPS and the organizers of this seminar for the opportunity to speak today. So my talk is going to focus on the classification and incidence of small cell carcinoma, high-grade neuroendocrine carcinoma of the prostate. I will go over the morphological spectrum that you can see with these tumors, focus a little bit on the role of immunohistochemistry and molecular workup in the diagnosis of these neoplasms, as well as touch upon some emerging biomarkers that have recently been reported. So in the past decade, there's been a lot of light shed on the molecular underpinnings of the neuroendocrine phenotype associated with prostate carcinoma, and particularly in the context of treatment with next generation androgen deprivation therapy or androgen receptor signaling inhibitors. So many attempts to propose a more uniform classification for these tumors have been undertaken. The table on the left shows the results of a meeting which was convened by the Prostate Cancer Foundation a decade ago, which classifies neuroendocrine tumors in prostate as usual prostatic adenocarcinoma with neuroendocrine differentiation, adenocarcinoma with Paneth cell neuroendocrine differentiation, carcinoid tumor, small cell carcinoma, large cell neuroendocrine carcinoma, and mixed small or large cell neuroendocrine carcinoma and acinar adenocarcinoma. The table on the right is the WHO classification of neuroendocrine tumors in 2017. The only difference is that this last category, the mixed small large cell neuroendocrine acinar adenocarcinoma, is subsumed into the category of small and large cell neuroendocrine carcinomas. With the treatment-related neuroendocrine tumors now recognized as a completely different entity because of a different pathobiological mechanism, the current edition of the WHO classifies all of these lesions under the rubric of treatment-related neuroendocrine prostate carcinoma. So neuroendocrine cells in the prostate are the third most prevalent cells in the prostate behind the secretory and the basal cells. They're thought to arise from endothermal derived pluripotent stem cells. And as you can see here, they're hard to see under the microscope, but You can spot them when you do immunohistochemical stains for synaptophysin or chromogranin. They have these interdigitating processes which go through the go in between the luminal cells and release secretions in the stroma. And although the exact function is unknown, it's postulated that they are involved in prostatic growth and differentiation by endocrine, autocrine, and paracrine mechanisms. So de novo high-grade neuroendocrine prostate cancer is very rare and comprise less than 1% of all neuroendocrine prostate cancer. In the Stand Up to Cancer study, which involved characterization of tumor samples within the clinical trials framework, the incidence of all neuroendocrine carcinomas was less than 4%, with the incidence of small cell carcinoma being less than 1%. In this other multi-center study with more prospective consecutive metastatic collection of castrate-resistant prostate cancer samples, the incidence of treatment-related small cell carcinoma was overall 17%, and more than 3/4 of these tumors were pure small cell carcinoma as compared to the mixed category. This is a study from our institution that expands on the cases in the Stand Up to Cancer dataset to cover over 400 patients. Here, approximately 11% had any neuroendocrine differentiation, of which small cell carcinoma constituted about 8%. And the lower panel illustrates patients who had received androgen receptor signaling inhibitors at some point during their treatment history. Both histologic neuroendocrine features as well as NEPC expression scores were higher in the post-ARSI treatment samples shown here in red. So circling back to the subtypes of neuroendocrine carcinoma, the various categories of neuroendocrine differentiation that we see in our practice here are pure small cell high-grade neuroendocrine carcinoma, combined small cell high-grade neuroendocrine carcinoma and adenocarcinoma, diffuse neuroendocrine differentiation, as well as Paneth cell change. And here, more than 80% of these patients had some therapy, either with androgen deprivation therapy or radiation therapy. And what we see is that the majority of pure small cell high-grade neuroendocrine carcinomas is seen in the metastatic setting, whereas patients with combined small cell adenocarcinoma and prostatic and neuroendocrine carcinoma, as well as Paneth cell neuroendocrine differentiation, is predominantly seen in the primary setting. So here's an illustration of a classic small cell high-grade neuroendocrine carcinoma, where you see sheets of tumor cells with a high NC ratio and with a high mitotic and apoptotic rate. You can appreciate here that there is prominent nuclear molding, which is a pathognomonic feature of these tumors. The cytoplasm is not abundant, and there are small to no nucleoli in these tumor cells. Now, morphologic features in small cell carcinomas can be misinterpreted as large cell neuroendocrine carcinomas. And these are illustrations from the lung, where you can see atypical features in these tumors, but these can also be seen in other tumors from other sites, including in the prostate. In the first panel on the left, you see an example of a tumor which shows more abundant cytoplasm, although the cytoplasmic boundaries are not well appreciated. In the middle, you see a tumor with more nested architecture, and this does not necessarily mean that the tumor is a large cell neuroendocrine carcinoma. You can also see prominent rosettes in small cell neuroendocrine carcinoma. So these are images from an astute observation made by Drs. Lee and Epstein in 2013 about the uncommon small cell-like changes that you can see in high-grade PIN, intraductal carcinoma, as well as invasive carcinoma. These are cells that are characterized, as you can see here, they're crowded, they're uniformly bland, and the nuclei are hyperchromatic. But the difference is the mitotic rate is quite low, the proliferation index is low, and they do not stain positive for neuroendocrine markers. The prior therapy status was not detailed in this report. but it's likely that these are not related to small cell carcinomas at all. This is an unusual finding and an uncommon finding, but still has to be kept in mind while you're dealing with the differential diagnosis. Here are examples of large cell neuroendocrine carcinoma, where in contrast to small cell, the diffuse sheeting, what you see here are large trabeculated arrangement of tumor cells, which can also show peripheral palisading, almost conferring a basaloid-like expression, appearance to the tumor cells. And as you can see here, the nuclei are more open, as in contrast to the hyperchromatic dense nuclei in small cell carcinoma. And you can also appreciate the presence of nucleoli. Now, these large cell neuroendocrine carcinoma in the prostate is very rare, and most cases in the literature are in the form of case reports. But this is one of the largest series that is reported, where the majority of the patients, 6 of the 7 patients, were post-ADT. 6 of these patients, the majority, except for 1, were combined with adenocarcinoma. The PSA was low in the majority of these tumors. Most of these tumors showed bone mets, similar to conventional prostatic carcinoma, rather than to small cell carcinoma, which often shows visceral metastatic disease. And the outcome was very poor, with mean duration to death, 7 months from the diagnosis of neuroendocrine cancer. Here's an example of the mixed or combined acinar and small cell neuroendocrine carcinoma, where you can see on the left that this is a classic small cell carcinoma, and on the right you see a classic adenocarcinoma with prominent nucleoli and acinar or pseudo-acinar arrangement of tumor cells. On the bottom panel, you can see that the TTF1 immunostain strongly marks the small cell carcinoma component. Now, TTF1 is a transcription factor that's not uncommonly expressed in neuroendocrine neoplasms. And small cell carcinomas of the prostate and other sites, about 50% of them can show positivity for TTF1. And therefore, this cannot be used in the differential diagnosis between prostatic primary and metastasis from the lung. And in the bottom right panel, you see that there's a mirror image with the TTF1 of the PSA, which stains the adenocarcinoma component. Here's an example of a mixed acinar and high-grade neuroendocrine carcinoma from the bone, that you can see that in the top half of the image, this is a small cell carcinoma, and in the bottom half is an adenocarcinoma. This, the radical prostatectomy in this case showed no evidence of neuroendocrine differentiation. And similar to the last case, immunohistochemical stains for synaptophysin marks this a neuroendocrine component, and that for PSA marks the adenocarcinoma component. In our experience, this pattern is almost exclusively seen in the primary site, and this was the only case that occurred in a metastatic site in our series. So what we face quite commonly is this scenario where you have a large bladder tumor in a bladder TUR, and the question is the origin of prostate or bladder? So this patient presented with a large tumor in the prostate and bladder with bone and soft tissue metastasis. There was no evidence of CIS or papillary disease. The histology was that of a small cell carcinoma. There was no conventional urothelial carcinoma or prostatic adenocarcinoma to help you out there. Immunohistochemical profile, it was positive for NKX 3.1, negative for NKX 3.1 and PSA. Synaptophysin was diffusely positive, and RB was lost in this tumor. So in this scenario, it becomes important to rely on molecular assays. I forgot to mention here, but ERG immunohistochemistry was also negative in this tumor. So when we sent it off for sequencing, this was the result. This tumor was positive for P53 mutation. There was loss of PTEN and RB1, and it was also positive for the Temper-Serb rearrangement. So, and impertinently, there was none of the mutations that are seen in bladder carcinomas, such as FGFR2, third promoter mutations, Mutations of chromatin modifier genes, ARID1A, KDM6A, were seen. So the diagnosis based on the overall findings was made of small cell carcinoma of prostatic origin, which was extensively involving the bladder. The other pitfall when you're presented with a high-grade neuroendocrine carcinoma is the frequent presence of extensive crush artifact, as you can see here in this tumor, where you're not able to discern the morphology and you see extensive tumor crushing. If this were in a primary site, you would have to rely on immunohistochemical markers, including Ki67, to tell the difference between adenocarcinoma and neuroendocrine carcinoma. Ki67 would also help you decide if it's a small cell versus a large cell. A small cell usually has a proliferation index of over 90%, and if you have a lower proliferation index to the order of 50 to 70%, it might perhaps represent a large cell neuroendocrine carcinoma. If this were present in a metastatic location, you would have to consider metastatic carcinoma of neuroendocrine derivation from another site, and even lymphoma, and your markers have to be tailored accordingly. So given the challenges of performing metastatic biopsies in many instances and the extreme variability in tumor morphology that you can see after therapy, there have been platinum-based trials that have been conducted for patients with what is called aggressive clinical presentation or anaplastic carcinoma, even in the absence of tumor biopsy. And these aggressive features include, as shown here, the presence of widespread visceral and lytic bone metastases, a bulky, high-grade, locally advanced prostate cancer, bulky lymph nodes, low PSA at presentation in the setting of a high tumor burden, high serum chromogranin, a short interval to androgen-independent progression after initiation of ADT, elevated serum tumor markers, and these tumors often harbor genomic alterations of P10, P53, and RB, similar to that seen in small cell and high-grade neuroendocrine carcinomas. The phenotype in this classic clinical presentation ranges from poorly differentiated prostatic adenocarcinoma or poorly differentiated adenocarcinoma without either neuroendocrine or prostatic differentiation, the so-called double negative carcinomas, which Dr. Hafner will cover in his talk, as well as small cell neuroendocrine carcinomas. So this is a study looking at clinical features of 47 de novo and 40 treatment-related neuroendocrine prostate cancers from Dr. Beltran's group, where less than half the cases in each of these two groups were pure small cell, and the rest of them were mixed small cell and adenocarcinoma component. And you can see here that the median overall survival from initial prostate cancer diagnosis of de novo neuroendocrine prostate cancer was significantly shorter, about 16 months, versus for therapy-related neuroendocrine prostate cancers, which is about a little more than 4 years. There was no difference in incidence of molecular alterations involving AR, RB1, P53, or DNA repair genes between the two subgroups. And in terms of P53 and RB1, in terms of individual genes affecting overall survival, only the co-occurrence of P53 and RB1 mutations were significantly associated with overall survival from the time of NEPC diagnosis for each of these two subgroups on univariate analysis. And this was not able to be confirmed on multivariate analysis. So what is the role for immunohistochemistry for neuroendocrine markers in clinical practice? In the case of clinically localized prostate cancer, unless there are clear morphologic neuroendocrine features, IHC is not recommended. Even if you see focal neuroendocrine differentiation in tumors, it's not shown to be associated with an adverse prognosis. In metastatic sites, it's particularly helpful in the presence of a small biopsy or then there's scanty tumor or there's marked crush artifact in the biopsy, where you can use IHC markers in this scenario in conjunction with the morphology. And additional robust molecular features that predict lack of response to ARSI still need to be defined. So what is a common diagnostic panel that we use when presented with this question? Especially in a metastatic site, the general approach is to perform both a pan-neuroendocrine immunohistochemical panel, which is chromogranin, synaptophysin, and INSM1, as well as a prostatic marker, which can be all of these prostatic markers listed here: PSA, NKX, PSMA, AR, and ERG. Up to 20% of neuroendocrine carcinomas, however, can be negative for chromogranin and synaptophysin, and you can rely on INSM1 in these cases. Here I have to tell you that if you have an overt morphological features of small cell carcinoma, no crush artifact, and you're able to discern the morphology, you may not even do the immunohistochemical stains, and it is possible to make the diagnosis of small cell carcinoma even on H&E. The caveats to doing the immunohistochemical panel are that AR and downstream markers of AR, PSMA, PSA, and NKX, can be variably expressed. They can, or they can even be absent. So a negative IHC panel for these markers does not rule out prostate origin in either not a neuroendocrine or a neuroendocrine prostate cancer. And the second aspect to remember that immunohistochemical stain for ERG may be weak or absent even in the presence of a genomic rearrangement, and FISH is recommended in this scenario. So just going back to the last point, there's a low level of discordance between ERG protein expression and FISH for ERG rearrangement in castrate-sensitive mets, but this number increases in castration-resistant prostate cancer, where almost a quarter of CRPC show only weak or negative ERG protein expression. And in these cases, it's important to confirm the presence of the ERG rearrangement either by FISH or by sequencing. ERG IHC also tends to be negative for the most part in both localized as well as metastatic carcinoma with neuroendocrine features. And here you can also use ERG FISH or sequencing to tell the presence of the rearrangement and to determine whether it's of prostate origin. So this is the multi-center study of 160 metastatic prostate cancer, castration-resistant prostate cancer patients that I briefly showed earlier, where approximately 27 were treatment-related prostate cancer. Approximately 75% of these are small cell neuroendocrine carcinoma, and the rest were mixed small cell and adenocarcinoma. Here on IHC, approximately 75% of the small cell carcinoma showed at least a 2+ nuclear AR protein expression, as compared to 87% of adenocarcinomas with 2+ AR protein expression. But it was seen that AR transcriptional activity was lower in the small cell carcinoma cases versus the mixed adeno-NEPC cases as well as the adenocarcinoma cases. Despite this, there were no clinical differences between treatment-related small cell carcinomas with and without AR expression. So this persistent elevated AR protein expression with a lower transcriptional activity suggests that there might be an alternative mechanism, perhaps an epigenetic mechanism, which controls AR transcription in these instances. I wanted to spend a minute highlighting the recent identification of subtypes of small cell lung carcinoma defined by RNA expression of phenotypic regulators, ASCL1, NeuroD1, PAU2F3, and YAP1 by Charlie Rudin and colleagues at MSKCC. This is a very nice paper by Marina Bain and Natasha Reckman, which shows, which characterizes the histology and immunohistochemical expression of these markers in small cell lung cancer. And here you can see that ASCL1 and NeuroD1 are mutually exclusive in the majority of cases, and both of these are neuroendocrine high, which means that they canonically express neuroendocrine markers. Whereas in the bottom panel, you can see that the cases that are ASCL1 and NeuroD1 negative show PAU2F3 expression, and these do not express neuroendocrine markers.
Hey, Anu, I have to jump in just for 1 minute. Just probably need to wrap up in a minute.
Okay. Just briefly, also to bring up the role of RB-IHC loss in this scenario, just to stress upon the point that RB loss can also be seen in castration-resistant prostate cancer, albeit to a lower extent, where you can find either complete or total loss or heterogeneous loss of RB expression. Here's an example of RB loss in a castration-resistant prostate cancer. There have been several, because there's no effective second-line therapies, there have been several newer drugs that have been developed in neuroendocrine prostate cancer. I just want to focus in the next minute on DLL3 targeted, this marker DLL3, on the basis of which antibody drug conjugates as well as bispecific T-cell engagers have been developed and are currently in clinical trials. Just briefly to highlight this study by Dr. Beltran's group, which shows that DLL3 is strongly expressed in the majority of neuroendocrine prostate cancers, and only about 10% of castration-resistant adenocarcinomas show DLL3 in a focal distribution. And this study showed, this image shows that the overall survival of DLL3 expressing cancers is poor as compared to the DLL3 negative cancers. And here's a case to illustrate the heterogeneity that you see in metastatic prostate cancers. This is an example of a liver biopsy, small cell high-grade neuroendocrine carcinoma in chromogranin positive, diffusely DLL3 positive. And you can see a nice correlation with the DLL3 positive lesions in the liver biopsy. However, there were other mets that were positive for PSMA as well on the PSMA PET scan. And this heterogeneity is fairly common in advanced prostate cancer and therefore renders it difficult to offer one therapeutic agent. So just to summarize, small cell high-grade neuroendocrine carcinomas are overall rare, but they're more common in the metastatic setting and post ADT ARSI treatment. There's a continuum of progression from AR-driven to AR-independent molecular state, a subset of which is associated with high-grade neuroendocrine carcinomas. The recognition of the spectrum associated with this continuum of progression is important for classification and management of these tumors. You can use IHC and molecular assays to help determine site of origin as well as to support evidence for adenocarcinomas present in the tumor sample. And there's been reports of novel predictive markers like DLL3, which offer new therapeutic opportunities, but these need to be further explored. Thank you very much.
Thank you so much, Anu, for the excellent talk. We're going to move right to our next speaker. Reminder to all participants to put your questions in the Q&A, and we'll curate them for the end. It's my pleasure to introduce our next speaker, Dr. Michael Hafner. He's a GU-trained pathologist and currently assistant professor in the Division of Human Biology and Clinical Research at Fred Hutchinson Cancer Center and an assistant professor of pathology at UW. His research is centered on molecular pathology of advanced prostate cancer, and including disease classification through morphologic, genetic, and epigenetic studies. We welcome Michael for his talk, which is entitled Recognition and Workup of Morphologic Variants of Castrate-Resistant Prostate Cancer Beyond Small Cell Carcinoma. Michael, please take it away. Michael, you're muted, so...
Thank you so much for the invitation, for putting together this really wonderful session on this important topic of prostate cancer biology. And as it was alluded to by Dr. Gopalan already, over the past decade, as new highly potent androgen receptor signaling inhibitors became available, we've seen a shift in the molecular phenotypes of castration-resistant prostate cancers, where tumors that used to be AR positive and negative for neuroendocrine markers now present as NEPCs, and we've seen the classification of those tumors in the prior talk. But one of the things that we also recognize is that there are tumors that evolve that are negative for AR and AR signaling markers, and also don't show any overt neuroendocrine differentiation. And in large-scale rapid autopsy cohorts over the past couple of years, it's really been seen that with the widespread use of these more potent AR signaling inhibitors, the numbers of these distinct molecular phenotypes that are characterized by either the complete loss of AR or the loss of AR and the gain of neuroendocrine features have greatly increased in prevalence. Now, when we look under the microscope at the morphologic features of castration-resistant prostate cancer, we see a plethora of morphologic patterns that we usually don't encounter in localized disease. Quite frequently, we can see squamous differentiation, pleomorphic giant cell, and of course, different variants of neuroendocrine differentiation. We've recently had the chance to look at these morphologic variants a little bit more closely in the University of Washington rapid autopsy cohort, and we're able to identify 14 different morphologies that we find in these patients that died of advanced metastatic prostate cancer. And what was gratifying really is that a lot of these morphologic changes that we can appreciate were associated also with transcriptional changes. But I think the challenge really is to have a very robust framework to read out these morphologies, in particular in limited metastatic biopsy samples. So we need to, I think about another way of disease classification. And really elegant work by my colleagues, Peter Nelson and Carl Morrissey over the years, leveraging large-scale transcriptomic data, have shown that you can classify castration-resistant prostate cancers just based on the absence or presence of AR signaling markers or neuroendocrine signaling markers in 4 distinct groups. And this transcriptional profiling now allows us really to bin relatively simply metastatic prostate cancers into these 4 groups. The adenocarcinoma type of cancers that are AR positive, neuroendocrine marker negative. The neuroendocrine prostate cancers that we heard about before that are AR negative mostly and neuroendocrine marker positive. Then this group of tumors that have expression of both AR signaling markers and neuroendocrine markers, and these double negative carcinomas. Now, of course, since AR is one of the key therapeutic targets in prostate cancer, you can envision that loss of AR results in inherent resistance. But even more so, these 4 groups are not just of intellectual interest, but they also are reflective in differences in outcome. Here I'm showing you a Kaplan-Meier graph for a relatively large biopsy-based cohorts from the Stand Up to Cancer effort. And you start to see that the tumors that are AR negative, neuroendocrine marker positive have definitely the worst outcome, followed by these double negative carcinomas. So there is a clinical relevance to this subclassification. But the challenge really was for us that the subclassification was based on applying relatively large transcriptomic data and then transcriptional signatures that are not easily translatable into clinical practice. So we performed benchmarking experiments trying to look for different IHC markers that we could easily apply that would allow us to perform this type of subclassification, but with just IHC alone. And to cut a long story short, we ended up favoring AR, NKX 3.1, synaptophysin, and INSM1 as 4 core markers that would allow for this subclassification in these molecular bins. And about 2 or 3 years ago, we started to reflex stain every metastatic biopsy in our institution with these markers. So let me just show you a couple of examples. For instance, here's an H&E micrograph of fully differentiated carcinoma of a 72-year-old man with a CRPC diagnosis. And you see Morphologically, it's giving us mixed signals. There's some cells with nuclear molding, others have a little bit of open chromatin and nucleoli. So morphologically, not a clear-cut diagnosis. This is IHC for androgen receptor completely negative, NKX 3.1 completely negative, synaptophysin strongly positive in this case. And here's INSM1 patchy reactivity. And Ki67 in this case, pretty high, about 50%. And I think there's an underappreciated value of using Ki67 in these metastatic biopsies. So this is just showing you the distribution of Ki67 across these different molecular subgroups. And you can see that irrespective of the molecular subgroup, you can have tumors with very high and very low Ki67 labeling indices. But it really suggests that there is this group of tumors that have Ki67 rates that are above 60%, that are probably in line with this pro-proliferative CRPC phenotype that has been described by Rohit Mehra and others. And these tumors likely have different biology and also different response to systemic therapies. So here's another case, I think, that is very helpful to take a closer look at. Morphologically, again, very challenging to interpret, lots of crushed artifact, but otherwise looks like a small round blue cell tumor. But now AR stain reveals very high AR expression, NKX 3.1 strongly positive, and neuroendocrine markers, synaptophysin, INSM1 are all negative. So this really shows that the standardized workup of these cases will allow us to subclassify tumors a little bit better. Another case here that was shared with me by my colleague Cornelia Ding. Morphologically, again, very challenging to immediately subclassify. AR, however, very strongly positive in this case. NKX 3.1 strongly positive as well. Synaptophysin strongly positive, INSM1 negative. And I think this allows us to talk a little bit about the complexity of these AR positive, neuroendocrine marker positive tumors. So first we see a group that has been termed Amphicrine carcinoma, and this is really an analogy to tumors that have first been described in the GI tract that express proteins both of a secretory exocrine and an endocrine component. And when we look at these Amphicrine carcinomas in the context of CRPC, what we usually see is tumors that have very high expression of AR and downstream AR markers, as well as high level of expression of downstream neuroendocrine differentiation markers such as synaptophysin and chromogranin. But the vast majority of these tumors are negative for transcription factors that are associated with neuroendocrine differentiation, such as INSM1, ASCL1, and SOX2. Now, we want to differentiate those tumors of this Amphicrine phenotype with those tumors that have more of a mixed or biphenotypic appearance, where we see, for instance, in this case, the vast majority of tumor cells being positive for AR and NKX 3.1, but scattered in a small subset of cells that express neuroendocrine markers. And now, again, these tumor cells also express neuroendocrine transcription factors such as INSM1, ASCL1, and SOX2. Now, maybe let's take a closer look at the features of these Amphicrine carcinomas. So these Amphicrine carcinomas are defined by the co-expression of luminal epithelial, AR, NKX 3.1, PSA, and neuroendocrine markers, synaptophysin, chromogranin, and others. We tend to use a cutoff of at least 70% expression of luminal and neuroendocrine markers and 50% co-expression of these markers. Most of these Amphicrine carcinomas have been shown to respond to AR-directed therapies. And what you see here in the Kaplan-Meier graph to the left is that outcomes are overall relatively similar to what we see in AR-positive neuroendocrine marker negative tumors. Most of these Amphicrine tumors are morphologically distinct from neuroendocrine carcinomas. They lack small cell features. And also their transcriptional, genomic, and epigenetic landscape is much more similar to the ones seen in AR-positive, neuroendocrine marker-negative adenocarcinomas. And this is also reflected in their expression of relevant molecular targets, such as PSMA and TROP2, where they show high expression similar to the AR-positive neuroendocrine marker-negative tumors. Most of these Amphicrine carcinomas show no expression of any PC-specific targets, such as DLPC, which was introduced in the prior talk. Now, maybe let's go back and think for a little bit about these mixed and biphenotypic tumors. These are really challenging because we don't currently have a lot of data and a good biological understanding of them. But here's a case, for instance, from our institution. This is an H&E showing you this tumor that grows in these smaller nests. But you can easily pick out that there are two cell populations, one with larger nuclei and more prominent nucleoli, and there's another cell population that is made up of smaller cells with a very highly hyperchromatic nucleus. Now, when we look at NKX 3.1 stains, we can start to pick these cells out, these smaller cells that are characterized by the absence of NKX 3.1 reactivity. And INSM1 IHC now highlights these small cells that are, in this case, localized more in the periphery of these nests. So we really have a two-part cell population present within this tumor. In a different metastasis, we were able to take a much closer look at one of these biphenotypic tumors and applied dual immunofluorescent labeling, really showing that there are two distinct cell populations that differ in the expression of AR and neuroendocrine markers. And again, when we take a closer look at the H&E here, we start to see also morphologically two distinct cell populations. And then single cell sequencing in this case really reveals that there are distinct cell populations present that differ greatly in the expression of the androgen receptor and also neuroendocrine markers, potentially suggesting that these tumors could be emerging or incipient neuroendocrine carcinomas. A couple of words maybe about this double negative prostate cancer or AR negative, any negative tumors. And I think in medicine in general, it's always a danger to naming things of what they are not, but it's very common practice across all different subspecialties. So let's maybe see how the DNPCs are really defined. I think we here in Seattle and other groups have really noted that DNPC is an emergent subtype, in particular in patients that have undergone ARSI therapy. It's clinically characterized by its lack of response to AR-directed therapies and relatively low PSA levels. And we see that most of these double negative prostate cancers showed very distinct morphologies that are different from what we see in neuroendocrine prostate cancer. In particular, we observe an enrichment in tumors that show squamous features, and also transcriptomic, genomic, and epigenomic analysis show distinct differences from these DNPCs to all other subtypes that I've shown you. The classification of DNPCs is really based on the absence of AR and AR target expression. And from a molecular targeting perspective, there have been several reports suggesting that these tumors are more dependent on FGFR signaling, and a couple of clinical trials have probed this. And more recently, there are also studies suggesting certain epigenetic vulnerabilities in these tumors. But it is clear that more work is really needed to identify unique ways to treat these tumors. Diagnostically, I think these tumors are very challenging because they are a diagnosis of exclusion. We need to rule out tumors of non-prostatic origin. And what we really need is a distinct positive marker to define this particular entity. So I think what I've probably shown you here is there's a very high level of complexity, and morphology or IHC in isolation are likely insufficient to accurately describe these relevant tumor features. But I think moving forward, we really need to define criteria and a terminology that we can all agree on for implementation in clinical practice, but then also for novel drug development. Because if we don't have criteria that define, for instance, these double negative tumors, it will be very, very difficult to conduct clinical trials in this space. And of course, these criteria we want to validate then in retrospective cohorts, correlate with outcome, and really start to understand also the interplay between these molecular subtypes and other genomic alterations such as RB, p53, p10 loss, transcriptomic changes, and DNA methylation alterations. So in order to do this, this is work by Misha Beltran and many others, got together a group of geopathologists, medical oncologists, and urologists to think about this problem of subclassification of CRPC tumors. And we were really inspired by the work in other tumor types where morphologic diagnosis are paired with molecular diagnosis. When we think, for instance, about breast cancer, invasive ductal carcinoma, ER positive, PR positive, HER2 negative, or in kidney cancer, renal cell carcinoma, SDH deficient. So the question is, are we ready yet to apply such a molecular classification to castration-resistant prostate cancer? And what the group really came up was a very simple and standardized diagnostic framework that can hopefully lead to an easy yet reproducible way of signing out and labeling these tumors. So we were thinking of applying 3 different classifiers that reflect the morphology, the IHC characteristic, and the proliferation of the tumor. For morphology, we want to be very, very simple and classify between adenocarcinomas, fully differentiated carcinomas that cannot be placed in either of the buckets, small cell carcinomas, or a group of other distinct morphologies that would include, for instance, tumors with squamous differentiation. The IHC classification should be based on a limited number of markers, ideally AR and NKX 3.1 to assess AR activity, and synaptophysin and INSM1 to assess the presence or absence of neuroendocrine differentiation. And Ki67 should then be used to classify the tumor in high, low, or intermediate proliferation rates. So a sign out for a case would, for instance, look like this: prostatic adenocarcinoma, AR positive, NE negative, Ki67 20%, or a small cell carcinoma, AR negative, NE positive, Ki67 70%. So this is at least an attempt to really standardize our sign out and clinical workup for these otherwise very difficult to handle cases. But I think we want to be aware also that cancer cells usually outsmart us, and most likely in the future, with the major efforts of profiling these mCRPC tumors, we will see a plethora of other differentiation patterns arising. For instance, there's increasing interest now in the gastrointestinal subtype of mCRPC, a more basal-like subtype, and the like. And I think as these research studies mature, we really have to think about biomarkers that we can bring into the clinical workup for these cases. And with that, I really want to thank you for your attention, and I'm looking forward to the discussion and Q&A session.
Wonderful. Thank you, Michael. So we'll go right into our last speaker. So we're very excited to have Dr. Beltran join us. I think it's always nice to have some perspective from the clinician, not just pathologists, in these sessions. So that's particularly exciting. So Dr. Beltran is a medical oncologist at Dana-Farber Cancer Institute, really focusing on the treatment of patients with advanced prostate cancer, in particular, really a world expert on patients with neuroendocrine prostate cancer. She's co-director of the Dana-Farber Center for Cancer Genomics, co-director of the Prostate SPORE at Dana-Farber and also the Director of Translational Research within Medical Oncology at Dana-Farber. And her lab has a focus on lineage plasticity and development of neuroendocrine prostate cancer as a mechanism of treatment resistance. So we're very excited to hear her perspective on this topic today. Thanks, Misha.
Thanks, Tamara. Thank you so much for having me. This has been a really excellent session. There's a little bit of overlap, I think, with my talk with some of the others, but hopefully I'll highlight some of my clinical perspectives as a medical oncologist, which I always love interacting with pathologists when thinking about this issue, and then highlighting some mechanisms in pathogenesis as we go along the way too. So we've heard already about the changing clinical landscape. It's really been really amazing to witness during my career, just a dramatic change in the way we take care of patients. Drugs starting in late stages of the disease, moving their way earlier, AR therapies, really potent AR therapies, but also PSMA-directed therapies and other systemic intensification approaches. So patients are living longer, but of course, the mechanisms of resistance are evolving, as we heard. And even after all these treatments, most patients still do progress with rising PSA, bone mets, lymph node mets, have sort of conventional AR-driven adenocarcinoma, and that's where really the basis for AR degraders and other ways to try to target the AR. But we do recognize that there are some patients with really rapid progressive disease, explosive disease, liver mets, brain mets, which we thought are still quite rare, but maybe increasing in incidence or awareness, often with low or non-rising PSA. And of course, PSA is AR driven, suggesting that their tumors are less AR dependent. And some, but not all of these, do display small cell carcinoma, which we've reviewed in the last two talks in great detail about the morphologic features that can look a lot like other small cell carcinomas from lung or other primary sites. So this is a sort of not a common case, but a typical case of a patient who had high-grade prostate cancer, was on hormonal therapy, had surgery, had radiation, had hormonal therapy, and eventually progressed with a PSA of 0.27 with a low testosterone, with multiple bone, nodal, liver mets, and in this case showed sort of a classical picture of high-grade small cell carcinoma. These are the markers that were done by the pathologist, and then genomics showing classical RB loss, P53 mutation, and TMPRSS2 gene fusion confirming prostate origin versus a second primary. So he was treated with hormonal therapy. He was still on hormonal therapy and got platinum-based chemotherapy, progressed through that. He had serum neuroendocrine markers checked, CEA checked, still very low PSA. And he had a PET scan. You can see the background of liver, which is PSMA positive, and all the liver mets being PSMA negative. So one could argue that this patient could have received platinum-based chemotherapy anyway, and maybe the biopsy didn't change. The initial biopsy didn't change what that patient received, but I think what's particularly important is to think about what to do next, whether we go towards a small cell regimen or something else. So when speaking with my colleagues around the world and regional differences, also that I would say that there's a lot of variability. Some people report never or very rarely seeing neuroendocrine prostate cancer. Other people say they see it all the time. And of course, there's been papers that have shown up to 15 to 20% of late stage prostate cancers developing either small cell or neuroendocrine features. And I think that the guidelines that we have, the NCCN guidelines, don't really give great guidance as to when to do a biopsy, so they're not always done. And then there's a variability amongst pathologists, and there's heterogeneity that have been also addressed. And when we think about the disease continuum, of course, this isn't really just an endpoint. There's a continuum, a process. And a lot of biology or biologic factors contribute to this lineage reprogramming from when you shutting down this AR-driven luminal program facilitated by underlying RB and P53 loss. We can see activation of lineage-derived transcription factors like ASCL1 and others. We can see transcriptional changes, stem-like programs, developmental pathways, cell cycle pathways, and then significant epigenetic reprogramming as tumors turn on this more differentiated neuroendocrine lineage. So again, there's no real guidelines as to when to rebiopsy. Likely universal biopsy for every patient post-AR therapy is of low yield. I personally consider this for patients that have very aggressive disease with low or non-rising PSA, PSMA negative lesions on PET scan, especially soft tissue or visceral, and a history of mixed features on a prior biopsy to see what the dominant lesion is to help guide next line therapy. This could guide early use of platinum, selection of clinical trials, or reaching to small cell lung cancer regimens. And we heard that there's a lot of variability even within neuroendocrine prostate cancer. And we published a paper, a retrospective, a small study, but trying to look at mixed versus small cell, de novo versus treatment emergent. In addition to the de novo patients doing worse, as Anu had shown in her talk, we also found that those with pure small cell had inferior outcomes compared to those with mixed features, as you might expect. But I think providing further rationale or importance for really understanding the heterogeneity that we do see. So over 10 years ago, back in 2013, this was a really illuminating workshop that I helped organize as a non-pathologist, but all the pathologists were there, and Tamara was there, if she probably remembers. And it was, I think at the end of that workshop, the proposed classification was on morphology, thinking if we could standardize the way pathologists read out the reports with morphology when it comes to neuroendocrine differentiation, this could be informative. But many of these things are not very common in treatment emergent disease like carcinoid or Paneth cell. And we saw this already in an earlier talk that the latest WHO classification just states treatment-related neuroendocrine prostate carcinoma with no distinction between morphologies or IHC markers. So I think doesn't necessarily capture the heterogeneity or the non-neuroendocrine variants that we might see. And so Michael talked about this updated workshop 10 years later. And so I do think that having multiple standardized markers in a workup could help us speak the same language in the clinic, but also in our clinical trials and our clinical studies as we start thinking about developing therapeutics targeting specific subclasses. And there's a lot of nomenclatures that are being used, trying to capture this heterogeneity. And I think that we're not going to be going away from morphology or IHC or genomics with I think we're going to need all of these moving forward when thinking about how these entities are distinct, or if they're within the same spectrum or continuum, and how they respond to different treatments. One challenge is that not all patients with clinical features of AR independence demonstrate obvious features on biopsy. You can still see adenocarcinomas that express AR, these so-called aggressive variant prostate cancers, which may have some similar genomics, but I think more studies are needed. And then we saw this also with the small cell carcinomas that can express androgen receptor. So perhaps this study was capturing patients earlier in their tumor evolution, and maybe loss of AR is a later event. These tumors, despite having AR, had lower AR signaling, and there was work by Amina Zubaidi at the University of British Columbia had shown in preclinical models that tumors, enzalutamide resistant, PSA low, plasticity models that still had androgen receptor, the AR systrome was redirected. So instead of binding canonical AR target genes, start to bind more stem-like genes and neuronal genes. So perhaps the androgen receptor is still functional in this situation and just redirecting the tumors towards a different lineage. So again, I think that a combination of histology, AR signaling status, the clinical context, which I think is still very important when driving clinical decisions, and molecular features could help, really help us in the clinic. And molecular features, I think, are still essential as we start thinking about trying to capture molecular subtypes in addition to what's being used today. So what the approach that we've taken is over the years is to try to capture the extreme ends of the spectrum, those AR positive adenocarcinomas, the CRPC tumors, and those AR negative small cell carcinomas, recognizing that there may be some, there are different subtypes in between. And one thing that's emerged from our studies and other people's studies is that one of the most distinguishing features are really the transcriptomic and the epigenetic features. And we can see dramatic gene expression differences between conventional adenocarcinoma and neuroendocrine prostate cancer. And a lot of these involving, again, EMT, stem-like, neuronal, neuroendocrine programs. And genomically, though, they're very similar to prostate adenocarcinoma, although enriched with RB and P53 loss. Otherwise, the copy number landscape is often very similar, reflecting their cell of origin and a clonal evolution from an adeno or a luminal cell of origin. In mouse models, it's been shown by multiple groups now in preclinical models that the combination of tumor suppressor losses can make tumors lose AR and develop neuroendocrine features in mouse models. But when we look at the Stand Up to Cancer Dream Teams and all the other CRPC data sets, some of the most common alterations in CRPC compared to adeno or to primary disease are P53, P10, AR, and RB. And many of these, even when they co-occur, are not neuroendocrine. So maybe they're prognostic, maybe they're early facilitators. In lung adenos that transform to small cell, the presence of RB and P53 precedes histologic transformation. So maybe they could be used as biomarkers for early intervention. The methylation landscape or the epigenetic patterns of neuroendocrine are really different than adeno. We showed this in looking at methylation of tumor biopsies, looking at DNA methylation. We can see segregation of neuroendocrine from CRPC adenocarcinoma. Some of our adenos having methylation profiles more like neuroendocrine were patients that had very low PSAs, aggressive disease. And people have seen this at other epigenetic platforms as well. Interestingly, in this study by Henry Long and multiple collaborators, Miles Brown and others, and they found that looking at a TAC-seq of neuroendocrine prostate cancer, these are PDX models from the University of Washington, that the chromatin profiles of neuroendocrine prostate cancer actually looked a lot more like other neuroendocrine carcinomas like Merkel cell, small cell lung cancer, and high-grade GI neuroendocrine carcinomas, and very different than the adenocarcinomas and localized TCGA data. In a prior study, we had tried to integrate genomic, methylation, transcriptomic data to come up with a classifier looking at transcriptome features. And we see that when we plot AR signaling with neuroendocrine score, that localized prostate cancer none of the TCGA cases had a high score, but when we started to go to the more advanced data sets, we see a shift, including the autopsy data sets, and the more recent Stand Up to Cancer, when they looked at neuroendocrine score against AR signaling, we not only saw the neuroendocrine tumors having a high score and a lower signaling pattern, but these tumors with RB-P53 loss having a sort of intermediary score, is suggesting again that maybe these are tumors that are in transition. I was really interested in this study. It was published several years ago now, looking at transcriptomic data from high-grade, low PSA tumors, primary tumors, and they found that when looking specifically at patients that had PSAs less than 2.5, that these high-grade tumors had higher expression of neuroendocrine and small cell markers and lower AR activity, and suggesting that maybe these tumors were kind of hardwired in the beginning to be more AR independent and aggressive, and maybe these are patients that are more likely to develop lineage plasticity, something that I think warrants further investigation. We looked at de novo small cell carcinoma prostate cancers, and I know others have have as well. This is a very rare subtype, but in this particular study, we found not only frequent RBP53, P10 loss, but also a few cases that harbored TMPRSS2 or gene rearrangements, suggesting that even de novo small cell prostate cancer may actually have a luminal cell of origin if we think that the TMPRSS2 or gene fusion is a sort of an adeno or a prostate specific marker. So a lot of the diagnosis right now is completely reliant on biopsies. And of course, there's always the challenge of heterogeneity. And there's a lot of work now being done on the imaging side and on the liquid biopsy side to try to capture heterogeneity to complement biopsies. We've looked at the methylation features that we saw in biopsies in plasma samples, looking at tissue and plasma samples, matched samples. We saw the same sort of hyper and hypomethylated regions detected in plasma as we did in tissue samples, and recently reported an assay called NEMO that is really geared towards a targeted panel that distinguishes neuroendocrine prostate cancer based on methylation features. And this was a collaboration with Francesca De Michelis of the University of Trento, but also many collaborators from all over, including Michael, who's on the call, where we looked at white blood cells versus tumor cells, and then looked at adeno versus neuroendocrine prostate cancer. And the platform is geared towards inferring tumor content, providing a phenotypic evidence score along a continuum. So not just yes or no, but recognizing that maybe we could capture potentially other subtypes and inferring transcriptional state. We looked at various different cohorts. Most CRPC cohorts, traditional early CRPC cohorts did not have a high phenotypic evidence score, but as we started going to later stages of the disease and those with biopsy confirmed neuroendocrine prostate cancer, we saw a high phenotypic evidence score, including some patients that had aggressive variant prostate cancer without biopsy confirmed neuroendocrine disease. And so we are excited to kind of continue to develop this in clinical trials. I think one implication of having a liquid biopsy assay may help prompt when to do a biopsy, which I think is still a challenge. We did apply the methylation panel to the LUCAP series and found that the methylation features distinguish the neuroendocrine tumors shown here in this dark red from adeno, but also the double negative prostate cancers were distinguished from the Amphicrine tumors, suggesting that maybe there are methylation features that are picking up these similarities beyond expression of the classical markers. And we've also looked at different transcriptional subtypes in organoid models that were recently described by Yu Chen and Ekta Khurana, which they described neuroendocrine and AR-driven subtypes, but as well as a stem cell-like and Wnt signaling-driven subtype. And we see actually a continuum of methylation profiles through these different subtypes, something that I think could be explored when thinking about dynamic monitoring when it comes to liquid biopsies. There's a lot of different other panels or other platforms that are being developed, including 5-HMC methylation patterns, nucleosome profiling, fragmentomics, different platforms to go beyond genomics in the cell-free DNA to detect phenotypic variants in prostate cancer, but also in other cancer types. And I think a non-invasive assay could complement patients like this, for instance, where we had this is a patient who had newly diagnosed prostate cancer, so a de novo presentation, relatively low PSA with extensive lytic bone and liver mets, and had a biopsy at the same time point. The prostate biopsy showed prostate adenocarcinoma, whereas the liver biopsy showed small cell carcinoma, and the exome sequencing of both of these were the same, except for the liver had RB loss, whereas the prostate did not. So they had P10 loss and P53 mutation, which was shared. So in this situation, a prostate biopsy in itself may not have captured the phenotype, the dominant phenotype of the patient that needed to be treated appropriately. We've been interested in targeting methylation, thinking that this may be important for the phenotypes that we see, and we've in a recent work led by Yasutaka in our lab, he knocked out DNA methyltransferases and found that this decreased organoid growth, tumor formation, and metastasis. And interestingly, the knockout of DNA methyltransferases, DNMT1 or DNMT3A, downregulated several neuronal transcription factors. Am I running late on time, Tamara?
Yeah, I think we need to wrap up so we can take.
Okay, sorry, I'm going to go quickly through this. I'll skip some of this. So I'll skip through all this. It's obviously, I was going way over here, but I will just focus the end on talking a little bit about DLL3 that was already brought up by Anu, but I think it's another way to kind of think about PSMA changes and DLL3 changes and FDG changes that we may see on PET imaging that may help guide biopsies, and DLL3 is part of the Notch pathway. Sorry, I always have too many slides. And so Notch is really important for normal development. It's on in neural stem cells and turned off during normal neuronal differentiation. And so delta-like proteins and ASCL1 all are upregulated during this transition from on to off. And the same thing I think is happening in prostate cancer as Notch signaling is turned off. This may be associated with these changes in development. And when we reintroduce Notch into neuroendocrine models, we can see changes in morphology and expression of neuroendocrine markers, including more luminal-like features, despite no expression of the androgen receptor. So I think that the biology of this plasticity continues to evolve, and I think we have loss of Notch. It may be one factor. And this is my summary slide, just to highlight again, as this session has, with multiple talks looking at different aspects of lineage plasticity and histologic transformation. And I think it is still a challenge to diagnose, but there's been a lot of progress thanks to lots of the work of the people on the call. And I'll stop there. So thank you so much. Sorry for going over.
No worries, that was wonderful. So we've had just a wonderful session of, I think, very varied talks across a spectrum of translational biology and biomarker work. I thought I'd just start by, some of the questions are very similar in the chat. So two questions that have kind of floated to the top are very pragmatic questions. Maybe we'll start with you, Anu, and then go to you, Michael, for the second one. Do you recommend the use of IHC in all prostate biopsies, particularly for AR and neuroendocrine markers? Maybe you can make this important distinction between what we might do in the primary untreated setting, versus recommendations in the CRPC setting. And I just add another question, which is, in the primary untreated setting, can you give us an example of some of the some of the findings that might trigger you to do neuroendocrine staining in that setting, for example?
Yeah, hi. That's a practical and question that we face nearly on a daily basis when you look at these biopsies. To answer that, I would say that if you're just looking at the primary setting and you're looking at a high-grade prostate cancer, which morphologically looks like a high-grade prostatic adenocarcinoma, then there is no need to do IHC stains. When you would start thinking about doing IHC markers is if you see any features that indicate neuroendocrine differentiation. In case of high-grade neuroendocrine differentiation, if you have enlarged nuclei, you have features of small cell, you have nuclear molding, you have less prominent nucleoli, high mitotic and apoptotic rate. And morphologically, you think of a neuroendocrine differentiation, then you can do neuroendocrine stains to confirm the presence of any differentiation. That being said, I would say that this is an uncommon scenario in the non-treated in primary high-grade prostate cancers de novo. So it has been shown that if you just see occasional new neuroendocrine marker positivity, there's no association with the adverse prognosis. So that's not recommended. In the metastatic setting, especially with the features that Michael showed with the Amphicrine prostate cancers, when you see compartmentalization, you see the presence of nucleoli, but you see sheeting of cells. So you see features that are in between a prostatic adenocarcinoma and raise the possibility of neuroendocrine. Then you can do prostatic markers as well as neuroendocrine markers. And you might either have one of each that's positive, or some of each group that's positive in terms of stains, in which you could call it a neuron diffuse or an amphicrine carcinoma, or it could support high-grade neuroendocrine carcinoma if the Ki-67 level is really high. So I think just to keep it simple, if you don't see any morphological features, if it's classic prostatic adenocarcinoma, do not do it in the primary setting. If there are atypical features in the metastatic setting, then there's need to do the markers.
Great. That's a great segue, I guess, to the question for Michael. So I don't know if I'm allowed, it's a spoiler here, but you're starting to propose these very discrete panels of markers to allow us to sort of bin in the CRPC setting, specifically cases into neuroendocrine positive or AR positive, negative, et cetera. Another question that I think has come up several times in the Q&A is, what do you do in the setting where there's a discordance between the morphology and the immunohistochemistry? So, for example, it looks like a small cell, but there are no, neuroendocrine markers being expressed, at least in the panel that you've devised, or vice versa.
Yeah, I think that's a very good question. As I try to really emphasize is that the way we envision this framework to work is really based on morphology and IHC as the two main pillars. So if you see clear-cut small cell carcinoma, then this is going to be your diagnosis. And if the neuroendocrine markers that are tested in the panel, or if extended neuroendocrine markers are used all negative, then this would be noted in the diagnosis, but it would not preclude from calling this lesion a small cell carcinoma. And I think there is also an evolution of our knowledge. I mean, we definitely know that a fraction of clear small cell carcinomas is negative for the common neuroendocrine markers. This has also been well documented in lung small cell carcinoma. And I think Dr. Gopalan has alluded to, there is a lot that we will probably learn and integrate from the studies that have already been ongoing in small cell lung cancer, where additional subclassification of small cell carcinoma is going to be possible, likely based on transcription factors, ASCL1 and NeuroD1. And I think that will be important for small cell prostate carcinomas as well. But I think we're just not there yet, and our numbers are certainly lower to have enough power, statistical power, to make these conclusions.
Great, thank you so much, Michael. Misha, I'd like to pose two questions. The first one is a clinical one. We've heard quite a bit today about these Amphicrine tumors, tumors that have both AR pathway markers as well as neuroendocrine. From a clinical perspective, and for the pathologist signing out these cases, what type of treatment recommendations are relevant in that setting? We think small cell high-grade neuroendocrine carcinoma, that's going to be platinum-based therapy, which is not typical in primary prostate cancer, as opposed to, let's say, urothelial carcinoma in a former time before recent trials. What can we what's going on in the patient management setting with Amphicrine carcinomas?
Yeah, no, that's a great question. I think where I've most commonly seen Amphicrine carcinoma are patients that present with de novo high volume prostate cancer, where they have very aggressive clinical features from the start, and they might, the tumors may have had atypical morphology, maybe metastatic biopsy, that neuroendocrine markers were done. So in that situation, I would still give someone hormonal therapy, obviously, if they and the standard of care would be a doublet, at least a doublet with an AR pathway inhibitor. I would do that, but I probably would consider intensifying if the patient had really high volume disease, intensifying with chemotherapy also, so-called triplet therapy de novo. And so that's where I do think that my general gist is that these patients probably do less well on hormonal therapy. We don't have good data to say that, and so that's why I think intensifying makes sense. I think that in patients with later stage prostate cancer who have progressed on hormonal therapies, and I get the pathology report back, I do put a lot of emphasis on, how much neuroendocrine differentiation is there? Is there some component of AR positive or adeno component? Because my first line regimen would be like a taxane plus a platinum versus an etoposide carbo plus an immunotherapy on a small cell lung cancer route. So I think that there are nuances in just even thinking about what to go for first line. But I think that those nuances are not necessarily always appreciated, I think, clinically, if you don't have that many options.
Great. And I guess one more mechanistic question, which I'll pose to you, Misha. Michael, feel free to weigh in on this as well. This comes from Jyoti Wang, who I think you know well. He's asking, has anyone obtained strong evidence in patients that lineage plasticity really happens, driving individual adenocarcinoma cells to small cell neuroendocrine carcinoma, as opposed to ruling out clonal selection where pre-existing neuroendocrine cells become small cell carcinoma after hormonal therapy? Your thoughts on that?
Yeah, I think that the only clinical evidence I think we have is really sort of when we do a matched genomic profile of a metastatic lesion and go back to the primary and show that there's concordance of genomic alterations or copy number alterations suggesting that they had the same cell of origin. But I actually think that they're from a single cell level and from I think that there is still clonal selection, and there may be specific clones even in the primary that were more poised to do that. But I don't think there's been more than that done clinically. I don't know, Michael, if you have any thoughts on that.
Yeah, I think it's an excellent question. And with the technologies available, especially with single cell genomics, I hope that this question will be definitively addressed in the near future. But yeah, right now, other than the associations that Misha had described, I'm also not aware of a study that really looked at this at very high granularity.
So I think with that, we're gonna wrap up the session since we're just a bit over time anyway. I wanted to thank Drs. Gopalan, Afner, and Beltran for the outstanding presentations, and encourage you to please look forward to additional announcements of sessions, including one coming in June on germ cell tumors in the advanced and metastatic settings from the GU Pathology Society. Again, thank you to all of our speakers, and if the speakers could remain on for just a moment once we finish.
Thank you.
Thanks so much, everyone.
So I'm gonna do this funny thing. If everybody could just look at their camera and smile. Thanks so much. Have a wonderful day, everyone.
Thank you. I'm sorry I went over to Tara.
Me too. I started the cascade. I really am sorry.
Sorry. Okay. Thanks. Have a good day, everyone. Thanks for inviting me.
Take care.
Thank
Bye-bye.
you.
Thanks for putting this together. This was wonderful. Appreciate it.